Hello class. So today the topic of our discussion will be on Propofol. Myself Dr. Amol Kumar. I am a I okay. So this so we can see this milky solution. This is one of the most common drugs used by us in the operation theater. Okay, and it looks milky. Uh, it comes in a vial of 10 ml or 20 ml. Here we have a 20 ml vial, and as we can see, per ml there is 10 mg of propofol. And these are the contents of propofol. We are going to discuss it further. Okay, so this is the chemical structure of propofol. Okay, it's this compound's name is 2,6 diisopropyl and phenol. 2,6 diisopropyl phenol. This is the carbon 1 2 3 4 5 6. So we can see at the carbon 2 and at carbon 6 we have two propyl groups and a alcohol group. So this is a 2,6 diisopropyl phenol. So the ingredients are, it has soybean oil, it has a glycerol. Glycerol acts as tonicity agent. We also mentioning about the concentration. It is 10% soybean oil, 2.25% glycerol, 12% egg phosphatide, which also acts as emulsifier. And then we have sodium hydroxide, which helps in maintaining the pH. What is the pH it keeps? pH of 6 and 8.5. So we all know that propofol is milky. It is a milky solution, and it is insoluble. It is an oily compound. Okay, it's an oily compound, and it is insoluble in water. So we need some vehicle for it to emulsify. All right. So we have egg phosphatide, which also acts as an emulsifier. Okay. So we are going to talk about next. We are going to talk about its mechanism of action. We are going to talk about its clinical effects. We are going to talk about how we use it in induction maintenance. Okay, and at the last we are going to talk about its side effects. Moving on. So now we can see that we are going to discuss mechanism of action. So it is a selective modulator of GABA A receptors. Okay, this is a very important term. It is a selective modulator of GABA A receptors, and what it does is it prevents the dissociation of GABA from the receptor. Okay, the GABA is itself an inhibitory neurotransmitter. GABA is an inhibitory neurotransmitter. The propofol acts on the GABA receptors and inhibits the dissociation of GABA from its receptor. So what happens is that the duration of GABA attaching to its receptor increases, which increases the duration of GABA activated chloride channels. Okay, and because of this, the transmembrane chloride conductance increases, which further leads to hyperpolarization of postsynaptic cell membrane and functional inhibition of postsynaptic neuron. Okay, there are some other actions also which propofol exhibits. One, it inhibits NMDA receptor. Second, it inhibits acetylcholine release in hippocampus through GABA A action, and it also helps in potential of activity at glycine receptors, which further contributes to propofol induced hypnosis. All right. So now we are going. Okay. So now we are going to talk about the pharmacokinetics of propofol. Okay, so propofol has a large volume of distribution. Okay, the volume of distribution is approximate 3.5 to 4.5 liter per kg, and it is 97% plasma protein bound. Okay, as soon as we give propofol, okay, and next the onset of it is a very fast onset of action, approx 30 to 45 seconds. We give propofol, and within 1 hour brain circulation time, we can see the onset of the drug action. And once we give propofol, the duration of unconsciousness is about 10 minutes. All right. So this is how the propofol distribution occurs in our body. Now we'll talk about its metabolism. Okay. So propofol gets metabolized either in the hepatic way or extrahepatic pathway. Okay. First, we are going to discuss about hepatic metabolism. So here we can see the propofol. The hepatic metabolism is very rapid, and it is rapid as well as very extensive. Okay, so this is the structure of propofol. We can see one is that it leads to glucuronidation and sulfate metabolites. It gets converted to that, and then further it is eliminated in urine. Other pathway is that it undergoes something called as this is called as ring hydroxylation. It either undergoes ring hydroxy. One second. Undergoes ring hydroxylation. So, as we said, the metabolism is rapid and extensive. It results in inactive, water-soluble sulfate and glucuronic acid metabolites, and they're further excreted by the kidneys. It also undergoes ring hydroxylation, and which enzyme helps in ring hydroxylation? It is cytochrome P450. And what does it form? 4-hydroxypropofol. This compound, the 4-hydroxypropofol itself, has some hypnotic action that is almost one third of the propofol's hypnotic action. Okay. So this is an overview of hepatic metabolism. This is extremely important to understand. Okay, the propofol converted to glucuronide metabolites, and these glucuronide metabolites are eliminated in urine. The metabolism is extremely rapid and extensive, and one pathway is it undergoes ring hydroxylation, which leads to formation of 4-hydroxypropofol. See, okay. Now we will talk about the extra hepatic metabolism. Okay, the extra hepatic metabolism is in two parts. One, we will talk about the pulmonary uptake, and second, on the kidneys, how kidneys and brain help in metabolism. So, pulmonary is responsible for approx 30% of uptake and first pass elimination after the bolus dose. You give bolus dose, and 30% of the drug will be eliminated by first pass metabolism through pulmonary uptake. Okay, what compound does it form in the pulmonary system? It is called as 2,6-diisopropyl 1,4-quinol. Alright, so, and one thing is that most of the drug that undergoes pulmonary uptake during the first pass is released back into the circulation. This is mentioned in Stollting's anesthesia. Alright, and next, the kidneys and brain, they also contain the same enzyme UDP glucuronil transferase. Alright, so what all we have discussed? We have discussed the structure of propofol, we have discussed how propofol looks, what are the contents of it. We have discussed the mechanism of action, how it acts on the GABA receptors. It acts on GABA receptors, it increases the duration of attachment, it increases strong chloride conductance, it causes hyperpolarization, and then we see the effect of propofol. Then we discuss the volume of distribution, how it is distributed, what is the onset of action, how long does it take for the consciousness to come back, and now we have discussed its metabolism. Alright. Okay, there are few scenarios in which we land up in OTs. Sometimes the patient comes who has, you are in ERCP posting or gastromedicine for gastrosurgery postings and all. You see patients, cirrhotic patients. Okay, you see patients whose liver function is grossly deranged. So can you use propofol in that? Okay, so despite the rapid clearance of propofol by metabolism, there is no evidence of impaired elimination in patients with cirrhosis of liver. This is taken up from Stollting's anesthesia. Again, okay, there is no impairment. There is no evidence of impaired elimination in patients with cirrhosis of liver. You can give the drug. And second, you see patients of CKD all the time. CKD patients are very much common in operation during our operation theaters. And if a patient has renal dysfunction, that too does not influence the clearance of propofol. Okay. One thing is drug can be administered. Okay, either you can give it as a bolus or you can use it in continuous infusion. Propofol is a very common drug used in TIVAs. Okay, in total intravenous anesthesias, along with other opioids like fentanyl, remifentanil, sometimes with dexmedetomidine. That's an alpha-2 agonist. Okay, so propofol is a very important drug which plays a big role in TIVA. So we can give it either as a bolus dose or we can use it as a continuous infusion during the surgery. Okay. This point, the propofol actually readily crosses the placenta, okay, but it is also rapidly cleared from the neonatal circulation. All right, okay. So we have on the screen this person. He is a legend. Okay, Michael Jackson. He is one of the biggest pop star one of the biggest pop star the world has seen, and might not see like him someone again in some few decades. He actually died because of this drug. He actually died because of the action of this drug. Okay, he used to take propofol, all right, and because of that, he had died. All right. moving on. So we are going to discuss about the clinical uses of propofol. Okay, the first use of the propofol is number one, induction of anesthesia. Then you can use it for intravenous sedation. You can use it for maintenance of anesthesia. You can use it for non-hypnotic therapeutic applications. All right. So first we are going to talk about induction of anesthesia. You bring the patient to the OT. You pre-medicate the patient. Okay, glycopyrrolate, midazolam, any opioid. Okay, and then you will start the induction with propofol. Okay, so how do you calculate the dose of the propofol? The propofol dose in a healthy adult is approx 1.25 to 2.5 mg per kg. This is the IV dose. Okay, and if the patient is a pediatric patient, they will require very higher doses. Okay, and why do they need higher doses? Because they have a large central distribution volume and higher clearance rate. The metabolism fast, the clearance rate is fast. You need a bigger dose as compared to adult. Okay, so after you give propofol, uh, how much concentration should be present in the blood for unconsciousness to occur is approx 2 to 6 mg per ml. This is the concentration of drug required in the blood for unconsciousness, but this is a highly variable volume. This is, I'm talking about a normal healthy adult. Okay, he's not a very elderly patient and not a pediatric patient, a moderate guy. Okay, and if the patient is very elderly, as I said, like pediatric, they also have exception to propofol. They require quite lower doses, approx 25 to 50% reduction in the dose. And why do they need the lower dose? Because they have a smaller central distribution in volume, and they have a reduced clearance, and they are very sensitive to the propofol. Okay, the sensitivity is increased. So if you can see this, the children and elderly patients, they have quite opposite. They have opposite mechanism by which they need more dose of propofol or lower dose of propofol. Okay, so you give propofol and how long do you wait? Okay, you give propofol and you see within 30 seconds the patient loses the consciousness and apnea occurs. Okay, and how much plasma? Like we said, we need 2 to 6 mg per ml for unconsciousness. Similarly, we need 1 to 1.5 mg per ml for with awakening. In this concentration, we can see awakening in the patient. Okay, you give the propofol. Okay, how do you know the propofol has started acting? We have given the propofol. How do we know apnea has occurred? Okay, so the answer to that is there is loss of verbal response. So when we see this phenomena, we know, okay, apnea has happened, propofol has done its work, and we are ready to go. We are ready to back ventilate and give that relaxant. Okay, but is it same for all the drugs? No, this is seen with propofol. Okay, but when situation is with thiopentone, what happens here is there is loss of eyelash reflex. Okay, propofol you give the patient an induction dose and you say him to count from 10 to reverse or whatever way. You ask him to speak about his home and all everything, and as soon as the verbal response is gone, you know the propofol has done its work. Okay, so here we have talked about how much dose you need to give a healthy adult, a pediatric patient, and elderly patient. What are the differences in the pharmacology of the age groups, and what concentrations you need to keep a patient sedated, that is approx 2 to 6 mg per ml. This is required for unconsciousness. How much concentration you need in the blood for awakening, that is approx 1 to 1.5 mg per ml. And so when the patient's propofol action is done, he has a very clear minded recovery. Okay, patient awakens completely without any residual CNS effects, and that is why this is one of the biggest reason why propofol had replaced thiopentol. In initial days, previously, thiopentone sodium was used as a major drug for induction agent, but now the propofol has taken over. Propofol is an excellent drug for daycare surgery. Propofol is an excellent drug if you want to put supraglottic airways and whatnot. I'll talk about it. Has lots of other actions also, which we are going to discuss in the further class. Moving on, why propofol, not thiopentone? Okay, as I said, ease of administration. You just take a propofol vial, load it into a drug, load it into a syringe, and that is approx 10 mg per ml, and you calculate the dose and you just give it. Unlike thiopentone, where you have to dilute it, okay, you have to dilute and that takes time, so it is not it does not have ease of administration. Propofol has a very clear minded recovery. Okay, pharyngeal relaxation is very good. You can use it very nicely. You can use supraglottic airways without causing much response, much okay, and there's a reduced chance of post-operative nausea, vomiting. Okay, the airway resistance profile is good. It has two actions. It is antipruritic, antiarrhythmic. Okay, it can also be used as a maintenance agent. These features differentiate it from thiopentone. Okay, but is thiopentone still an option? Have we totally eliminated thiopentone? Answer is no. Thiopentone is the anesthetist should consider thiopentone in few situations. Situations like hyperthyroidism. Why? Because thiopentone converts the peripheral conversion of T4 to T3. Other in pediatric patients and pregnant patients and patients with shock. So propofol, we'll discuss its further action. Propofol causes massive reduction in systemic vascular resistance and cardiac output. This is not good if a patient is shocked. It is actually both thiopentone and these are relatively contraindicated. But if you want to choose a demon between both of them, propofol and thiopentone, propofol is the worst demon. You don't want to give it in shock. Okay, next is intravenous sedation. Okay, when we will take a class on total intravenous anesthesia. There we are going to explain you the things such as context sensitivity, half time, and all. For now, you just understand that propofol has a short context sensitivity, half time. Okay, and it has a short effect site equilibration time. So for intravenous sedation, the dose you need is approx 25 to 100 mics per kg per minute IV infusion. And for maintenance, okay, this is for sedation, but for maintenance you need even more dose, that is approx 100 to 300 milligram per kg per minute. Okay, all right. Okay, I'm sorry, this is an error here. It's not milligram, it's microgram per kg per minute. Okay, 100 milligram per kg per minute. Please don't give it to the patient. Okay, the and how maintenance? How do we reduce the dose of propofol? Okay, you don't need to give so much dose of propofol all the time. You can reduce it. How? With the propofol, you can simultaneously give an opioid. Okay, so opioid will act, especially this fentanyl group of drugs, fentanyl, morphine, and all that remifentanil. It will act along with propofol and reduce the required dose of propofol. Okay, and one thing very good about propofol is that it lowers the BP and helps in hypotensive anesthesia. So the blood loss will be less, and the surgeon will also be very happy with you. There are some non-therapeutic applications also. It has anti-emetic effects. Okay, reduces post-operative nausea, vomiting at a dose of, what is the dose? This is asked very commonly. That is 10 to 15 mg IV. Okay, and how does it do that? Okay, it is also effective against chemotherapy-induced nausea, vomiting. Okay, the most probable mechanism is subcortical modulation or direct vomiting center depression. That is CTZ. Direct vomiting center depression will be done, or subcortical modulation will be done. And one more thing, it does not inhibit gastric emptying or act as prokinetic drug. It does not cause gastric emptying. Antiemetic effect is there, antipruritic effect is there, or approximate dose of 10 mg IV. Antipruritic, where do you see? In liver failure and all, when there is cholestasis, you see antipruritic effects. Okay, or when you give Neuraxil opioids, that also causes histamine release, and you can see pruritus, so that also is prevented. Okay, other is it also has anticonvulsant action. Okay, we go to we do get posted in psychiatry department for ECTs, electroconvulsive therapies. We know that the patient they tourniquet one leg of the patient and then they give the shock. So you see a seizure for a few seconds, and you know when the seizure exceeds a lot, you have to give a bolus dose of propofol. So propofol has anticonvulsant action also. Okay, approx in a dose of 1 mg per kg, it reduces the seizure duration by approx 35 to 45% during the electroconvulsive therapy. That is also done by the similar mechanism of action, GABA mediated inhibition. Okay, one more thing is that it causes attenuation of bronchoconstriction. Okay, but if the propofol has metabisulfite as its preservative, then this thing causes bronchoconstriction, especially in patients who are asthmatic. Okay, propofol attenuates bronchoconstriction. Okay, but this metabisulfite part, this can aggravate bronchoconstriction if present. but nowadays most of the preparation it is present. Okay, as we said, if you give it together with opioids, the dose of propofol reduces. Which opioids? Phenylpyridines, fentanyl analogs. They have synergistic pharmacodynamic action. Okay, higher the opioid dose used, lower the propofol dose required for adequate analgesia. All right. Now we want to talk about systemic effects. What are the effects seen on the various organ systems of our body? The first we are going to talk about the central nervous system effect. Okay, so the first one is cerebral effects. What does it do? It reduces the cerebral metabolic rate for oxygen. The metabolic rate for oxygen is reduced, the blood flow, the cerebral blood flow is reduced, and the intracranial pressure is reduced. So it is a good drug for neurosurgery. All right. Okay, and when you administer it in patients who have raised intracranial pressure due to some space occupying lesion, then also it does not cause very aggravate increase in the intracranial pressure. Okay. Second is, if you give large doses, then it can cause a fall in the it can lead to a fall in blood pressure, and it can also potentially decrease the cerebral perfusion pressure. Then there is something cerebrovascular autoregulation. What is autoregulation? Autoregulation to systemic blood pressure changes is preserved. Whatever the body acts to regulate the fall or increase in blood pressure, that is preserved. Autoregulation is preserved, and reactivity of cerebral blood flow to PaCO2 changes remain intact. If you are doing laparoscopic surgery and you see hypercarbia or increase in carbon dioxide concentration, the whatever the cerebral blood flow changes occur because of those that is totally preserved. Okay, and you know when you have the anesthetic effect in EEG, first there's beta, then alpha, then theta, gamma, beta, alpha, and then there's theta, and all those steps in the anesthesia. Okay, when as you go then there's burst separation, and then there is a total isoelectric flatline. Okay, so these are the stages of anesthesia which are seen in EEG. Okay, so propofol also produces the EEG changes which is similar to thiopentol, which also includes burst separation and at higher doses. Okay, burst separation does occur with propofol. If we will discuss this EEG findings when we try to understand neuromonitoring in a separate class, but for now you understand these are the stages of anesthesia which occur with IV administration. Okay, and in neuromonitoring we read something about somatosensory evoked potentials. Okay, that also we will discuss further, but for now you understand that it does not alter somatosensory evoked potential a lot. Okay, we all know that midazolam causes amnesia, but and propofol also has similar memory impairment like midazolam. Okay, thiopentol however has a less memory effect and fentanyl has none. So here we talked about central nervous system. Okay, now moving on to cardiovascular system. We all know as soon as we give thiopentol, the blood pressure falls. I'm sorry. As soon as we give propofol, the blood pressure falls. Okay, but why does it fall? Number one, why? Because there is decreased cardiac output, and second, there is decreased systemic vascular resistance. All right, there is a decreased cardiac output and there is a decreased systemic vascular resistance. And in what situations propofol, the hypotension by propofol is aggravated? It is aggravated in hypovolemia, in the elderly, and in patient who have a compromised left ventricular function. Their left ventricular function is compromised. Okay, okay. Why does these things happen? Why there's decreased cardiac output? Why there's systemic vascular resistance? Why the SVR is decreased? See, this cardiac output is decreased, systemic vascular resistance is decreased. These two things are decreased. Why? One. So what happens is there is inhibition of sympathetic vasoconstrictor nerve activity. The vasoconstriction is lost, so all the nerves are dilated. So the resistance which occurs to the resistance for the left ventricle is reduced. The systemic vascular resistance itself is reduced because there is no constrictor activity in the vessels. And second, there is decrease in intracellular calcium availability. So calcium is required for the cardiac contraction, right? So if the calcium availability is reduced, definitely it is going to have a negative ionotropic effect. All right. So these are the two actions why the propofol causes fall in systemic vascular resistance and fall in cardiac output, which further leads to fall in the blood pressure. Okay. And next we are going to talk about how when you do laryngoscopy, you do get laryngoscopic response. The heart rate is increased, the blood pressure is increased, there are lots of changes, ICP is increased, but these are all response to laryngoscopy. Okay, so how does propofol help here? It reverses blood pressure reverses blood pressure reduction during direct laryngoscopy and tracheal intubation. How? It blunts the hypertensive response to laryngeal, and also it blunts the hypertensive response to laryngeal mask airway placement. It reverses blood pressure reduction during direct laryngoscopy and tracheal intubation, and also when you put LMAs and all, it blunts the pharyngeal responses. Okay, so it's a very good drug for that. Okay, this line typically unchanged. The heart rate is typically unchanged despite the decreased blood pressure. This line has been taken from Stolting's pharmacology. Okay. Uh, the heart rate remains despite such a big fall in blood pressure. The heart rate remains typically unchanged. But one thing, the baroreceptor reflex which takes place, that is definitely depressed by propofol. Okay, there is a possibility of bradycardia and asystole. So whenever that happens, anticholinergics are recommended. Okay, we give anticholinergics, and we are going to talk about this a little more. Okay, before we so propofol has reported bradycardia related death in few studies. Okay, so there is profound bradycardia and asystole after administration of propofol in healthy adult patients, even if you have given prophylactic anticholinergics in pre-medication. Okay, so but it is very rare. Okay, and it rarely proceeds to arrest. And how do you treat it? You just stop the propofol. You avoid aggravating surgical. You don't give surgical stimulus. Okay, then you start giving atropine in incremental doses, and sometimes you need a treatment with direct beta agonists such as isoproterenol. All right. Coming back, we saw blood pressure effects. How does that mechanism occur? We saw the effects on heart rate. We saw the laryngoscopic response, and now about the sympathetic and parasympathetic responses. It decreases sympathetic activity. Okay, very important. It decreases sympathetic activity. Okay, this line itself is a little bit contradictory to the last thing we said, but we have taken it all from Stolting's, how they have tried to mention it. Okay, it decreases sympathetic activity, then parasympathetic, and one sec. The parasympathetic reduction is more than the sympathetic reduction is more than parasympathetic reduction. Okay, and what it leads to? It leads to a relative parasympathetic dominance. There is parasympathetic dominance after propofol administration. Okay, so parasympathetic action is actually reduction in the heart rate, technically. Okay, and one more thing is that it does not alter the sinoatrial node or AV node function. So whenever there is this arrhythmia patient, especially Wolff Parkinson White syndrome, it is totally safe to administer propofol in them. All right. And one thing, whenever we give nitrous oxide, there are lots of systemic changes, but in association with propofol, there are no cardiovascular effects. Okay, if you give additional nitrous oxide along with propofol, addition of nitrous oxide does not alter cardiovascular effects of propofol. All right, and if you give ephedrine after the fall in the blood pressure by propofol, definitely the pressure response, the augment there is the pressure is the pressure augments the pressure response to ephedrine. Propofol augments the pressure response to ephedrine. All right, we have talked about this. Okay, next about the respiratory system. Okay, definitely this we are going to discuss it quite fast. This dose dependent depression of ventilation. Okay, 25 to 35 patients of patient experience apnea normally also. Okay, without the full induction dose. There is opioid. If you give opioids, the dose of propofol required is less. Okay, and if a patient undergoes some painful stimuli, that can counteract ventilatory depression. Whenever you use in TIVA and the patient starts to feel surgical stimulus, okay, the ventilatory depression effect is counteracted by the pain stimulus. Okay, now hepatic and renal function, as we discussed it before also, but we'll discuss it again. Propofol does not affect liver transaminases enzyme. There is no effect on the lefties. Okay, but if you give it in a prolonged infusion, okay, we are going to talk about it more in propofol infusion syndrome. If you give it in long infusions, definitely it is going to cause hepatocellular injury, lactic acidosis, bradycardia, and rhabdomyolysis. We are going to discuss it more further in propofol infusion syndrome. Okay, we are going to discuss about that later. What is this? Okay, um, all right, I'll show you this topic. Okay, and then okay, there are rare instances of where the hepatocellular injury after administration of anesthesia has been correlated to propofol. Okay, we can see green urine. If you use prolonged propofol infusion, it further leads to green urine. Okay, why? Because there are phenols causes green urine. But if such thing happens, it does not mean that the renal function has been altered. The renal function is totally fine. Okay, second, sometimes what happens is the uric acid excretion is increased. With what that can This is green urine, and what this can cause, the uric acid excretion can cause is cloudy urine. Okay, but both there is no renal impairment. Okay, in both the situations there is no renal impairment. Okay, further we are just going to discuss this IOPs. There's a propofol does cause significant decrease in intraocular pressure. Okay, uh, the lower intraocular pressure with propofol compared to isoflurane. Okay, propofol does not alter coagulation test or platelet function, and it also inhibits platelet aggregation induced by pro-inflammatory lipid mediators. Okay, so we see all the effects on IOP, we saw the effects with isoflurane, we saw the effects on coagulation profile, and what it does to platelet aggregation. So now next we are going to see the side effects. We are coming to the end of the discussion. We are going to see the side effects. Side effects could be either immediate or it could be after prolonged infusions. First we'll discuss the immediate side effects. Okay, immediate, all of us know the most common is pain on injection. Okay, pain on injection is the most common side effect. Okay, and we do take preventive measures to counteract that, like we use the IV line is placed in somewhat larger veins. Okay, we avoid the dorsum of the hand. The lines are very painful, you know. Or we can treat the patient with some we can give some pre-treatment with opioids or NSAIDs. Okay, or we can administer 1% lidocaine before injection. In the local vein we can administer 1% local lidocaine before injection, or you can use carrier composition with long medium chain fatty acid. You can use a carrier composition, some different composition of propofol, which will reduce the pain of injection. Okay, so in some people, sometimes what some situations we see that in propofol we mix lignocaine and then we administer it together. So in Stoltings, it is clearly mentioned that it has been seen in some studies that that causes dissipation of the propofol molecules, and which further could increase the risk of pulmonary embolism. Okay, I don't have the screenshot right now, but it's mentioned in Stoltings very nicely. Okay, so this is one of the biggest. This is one of the biggest uh, demerit of propofol. Other, obviously, there's hypotension, there's bradycardia. Okay, this can be used by reduced dose of propofol. How? We can give opioid together. Opioid will reduce the dose of required propofol. Okay, there is allergic reaction. Why? Okay, and then there could be it could sometimes it could be pro-convulsant. How? There is spontaneous excitatory activity due to increased subcortical activity. The subcortical activity will be increased, which could further lead to excitatory activity. Okay, so whenever the patient is poorly epileptic, use it with some caution. Okay, it is like a double-edged sword. Okay, in if patient is poorly epileptic, use propofol with little caution. Okay, and in some situations the myoclonus and meningismus has been reported. Okay, some other side effects of prolonged infusion. One, it's, it is a lipid emulsion. Okay, wherever there is lipid, it will be a very good culture media. So we can see it supports the growth of E. coli, Pseudomonas. What are the preventive measures which you take? You can use aseptic technique. You can disinfect the ampule neck. Okay, The vial will be kept in your OT in a container. You just take it and you disinfect it prior to loading the drug. Okay, you withdraw the drug with sterile syringe. Don't use repeated syringes. Use it with a proper sterile syringe. Okay, and whichever propofol is unused, you discard it within 6 hours. Within 6 hours, you should discard it. Okay, and the IV lines, the cannulas which are placed in the patient, that should be flushed, because if there's stasis, that itself might have some bacteria or something. We don't want to take any chances. We'll just flush the drug before administering the propofol. Okay, propofol definitely does have abuse potential. We talked about Michael Jackson. Propofol does have abuse potential. Okay, why? Because it is linked to the dopamine accumulation in nucleus accumbens. Okay, the effects are in this intense dreaming, this amorous behavior, this sexual fantasies and hallucinations during recovery. These things are seen during recovery. Okay, it is a triglyceride compound, so definitely it can also lead to pancreatitis. Okay, because it is the because the preparation is of lipid compound. It can cause hypertriglyceridemia. Okay, it's a thick solution. It can cause thrombophlebitis, and in some situations there is immunosuppression also. Why? Because it inhibits phagocytosis and bacterial killing, which reduces the lymphocyte proliferation. All right. So this is the propofol. Okay. Now we are coming to the last topic of propofol. That is what? Propofol infusion syndrome. All right. Okay. Uh, okay. So for propofol infusion syndrome, the first thing you should know is what is the duration of infusion that uh, should be given before you start considering the patient has propofol infusion syndrome. It is for more than 48 hours. Okay, patients who are receiving propofol for more than 48 hours. Okay, and what is the dose? The dose the dose is more than 75 mics per kg per minute or more than 4 mg per kg per hour, and over more than 48 hours. Okay, it is more in children. It is more in children. Okay, and wherever you use for sedation propofol, like mostly use this in ICUs and all. Okay, so there we have to be very careful about knowing the propofol infusion syndrome. Okay, duration of an infusion should be more than 48 hours. Okay, so what happens is, what are the other risk factors when the patient has some illness, as CNS organ illness or some sepsis or some respiratory organ or some pancreatitis? These are the illness which increase the risk of risk. Okay, and then if the patient is receiving some supplementation of catecholamines or corticosteroid, then it is a risk factor. Okay, and if the patient is quite NPO, there is an inadequate carbohydrate consumption, that also is a risk factor. And some patients, some mitochondrial myopathies are there, some mitochondrial diseases are there. If some situations like that is there, then that is also a risk. What is the pathophysiology? See, this is more of biochemistry. Okay, but we'll try to understand. These are some that cholesterol synthesis pathway and all. Okay, so what happens is, after you give propofol, okay, after you give propofol, there is increased activity of malonyl coenzyme. What does that do? It inhibits the synthesis. It inhibits the carnitine palmitoyl transferase. Malonyl coenzyme activity is increased, which leads to inhibition of carnitine palmitoyl transferase, which further leads to inability of fatty acids to enter the mitochondria. Now, fatty acids are unable to enter the mitochondria, which further leads to uncoupling of beta oxidation of fatty acids. Okay, the fatty acid beta oxidation uncoupling occurs, which further leads to imbalance between energy supply and demand. Okay, so there is a because of such things. Okay, the fatty acids are unable to enter the mitochondria. So another pathway for energy consumption is taken, beta oxidation, and then there is imbalance between energy supply and demand. So what happens after that? One, this proteolysis is increased. Second, mitochondrial inhibition occurs, and third, myofibrillar degeneration occurs. So because of this increased proteolysis, the proteolysis with the protein breakdown occurs. This further leads to myopathy or rhabdomyolysis. This is further due to this myopathy and rhabdomyolysis is secondary to proteolysis, which occurs due to the energy and supply mismatch. Okay, and if there is rhabdomyolysis, we all know it will progress to ARF, acute renal failure. Second way how the body tries to counter is mitochondrial inhibition. That again will increase the free fatty acids, and whenever this free fatty acids, it can lead to arrhythmias. Okay, free fatty acids can lead to arrhythmias. Last, It leads to myofibrillar degeneration, which further leads to arrhythmia and heart failure. Heart failure can lead to shock. Shock can lead to also ARF, or shock can lead to acidosis. All these things are seen in ICU. See, these are not very much seen in operation theaters. These are very commonly seen in ICUs where propofol is used as a sedative agent. All right. There can be acidosis, there can be protein breakdown, there could be rhabdomyolysis. Okay, these features are seen. Now we'll see the clinical features of propofol infusion syndrome, and how this happens we have just discussed. But now we'll summarize it. Okay, the first thing is metabolic acidosis. We see metabolic acidosis with base, and if it is there, then it is very profound with a base deficit of more than 10 millimole per liter. What is base deficit? We'll try to discuss it in acid-base class chapter. For now, you know that base deficit will be more than 10 millimole per liter if metabolic acidosis is there in the propofol infusion syndrome. Second, along with metabolic acidosis, another acidosis can be there, that is lactic acidosis. Why? There will be elevated lactate levels. Okay, lactate levels are increased, then potassium levels are increased, which will lead to hyperkalemia. Okay, then there is hyperlipidemia, hypertriglyceridemia. Okay, then we try to explain here how the heart failure occurs. So cardiac issues which will be seen are acute refractory bradycardia, you can see sinus arrest, you can see asystole, you can see cardiomyopathy, you can see cardiac failure and hypotension. Liver involvement is also there, you can see liver and you can see hepatomegaly after prolonged propofol infusion. You can see skeletal myopathy and rhabdomyolysis because of proteolysis and muscle breakdown. Okay, and all these breakdowns and electrolyte imbalances all can lead to something acute renal failure. So how are you going to detect? Okay, how are you going to detect the patient is going to develop propofol infusion syndrome? There are markers which can tell about it early to you. Number one is, if you see an unexplained metabolic acidosis in patient on prolonged propofol, suspect. Second, you are going to see lactate, creatinine, and myoglobin levels rise, especially lactate and creatinine. If you see them rise, you are going to suspect propofol infusion syndrome. If for some reason you are also going to see the lipid levels early, then that will also be shown increasing. So hyperlipidemia, and there will be some ECG changes also, such as the ST elevation in V1 to V3. Okay, now you know that this is going to happen. So how do you prevent? Number one, either you stop it or you reduce the propofol and change sedation to some other modality. You reduce the dose of duration of propofol. You avoid prolonged or continuous infusion. You know this patient is susceptible to propofol infusion syndrome. You do not give prolonged infusion doses. Okay, and even if you do, it is on a very reduced dose. Okay, you avoid it in children. You avoid it in patients who are having mitochondrial diseases, mitochondrial myopathies. Okay, you ask the patient, you give him nice feeds. Okay, carbohydrate intake is good. Okay, and you avoid any kind of lipid overload. Don't give any lipid solution, you avoid lipid overload. Okay, and then you also monitor the serum triglycerides. Okay, now the propofol infusion syndrome has happened. How do you treat it? Number one, the most important, discontinue the propofol infusion. Don't think twice, just discontinue the propofol infusion syndrome, propofol infusion. Okay, and there are lots of alternative sedatives in ICU. Okay, that itself is a chapter in critical care. What are the sedation? What is sedation score? How do you see sedation? How to maintain sedation? For now, you have lots of modalities for sedation. You can use opioids, you can use naltrexone, you can use fentanyl. There are lots of modalities, but don't use propofol as a modality for sedation. Okay, all the hemodynamic parameters that are delayed, you have to maintain them. You have to give IV crystalloids, colloids. Okay, you have to give fluid. If the patient's blood pressure is not stable, you have to use vasopressor inotropes. And if this heart block or cardiac failure type of situation arises, you might need to give transvenous pacing. The cardiac pacemaker should be put. Okay, and one thing is there, that you stop any lipid intake. Okay, lipid should be controlled in a very good way, and carbohydrate should be administered in a very good way in a case of prolonged propofol infusion. All right, you can give dextrose as carbohydrate. Okay, 4 to 8 mg per kg per hour glucose in IV fluids. Okay, that's it. This we have discussed. So with this we will conclude the class of propofol. Okay, I have tried to cover lots of topics, how propofol is interacting with the opioid, what are the mechanisms of action, what if something is left, I will definitely cover it in further lectures. But for now, I have tried to cover propofol very well. propofol infusion syndrome. I have tried to explain it to you. Okay, I hope I have made things clear. I have tried to explain you all the hemodynamic parameter changes, what are the mechanism of action, how propofol can affect your organ systems, the cardiac, the CNS, the RS, the IOPs, and I hope you find it beneficial. But I would really like if you can comment and you can tell me that what's pending, what I have done wrong, and what all. I'll pin your comment and let's try. Okay, thank you so much.